Glen Bradford is a HIV positive man and has been involved in the HIV community as both a social worker and an educator. Today, Glen will present Peer Navigation program for people newly diagnosed with HIV.
Hi everybody, it's great to see some old faces that I haven't seen in a long time, and I want to thank you for inviting me here today. Well, that was really interesting, Michael, because I was really nervous about my presentation and how it would roll out with the research that you've done. And I have to say, absolutely everything that your research has shown, we have seen in our workshops. So we should do a roadshow together. So I'm here to talk about newly diagnosed people, and specifically newly diagnosed services at BCPWA. A couple of things that we need to cover for me first. It's estimated that 15 to 30% of people who are HIV positive don't know it. This accounts for up to 50% of all new infections. Transmission most likely occurs at the time period immediately after infection when someone has a high viral load count. For a number of reasons, average length of time to access HIV service organizations is a gap of 2 to 3 years. So when they're hyperinfectious, they're not getting help. People diagnosed with HIV after 2006 approximately are the third cohort and the focus of this presentation. And this is really an important point because we have to see this disease in 3 parts. The first cohort is before 1996, before antiretrovirals came into play, where the theme was AIDS equals death. The second cohort is when antiretrovirals came into play, but they were really hard on our bodies and they had a ton of side effects. But as of 2006, we're down to 1 pill once a day with minimal side effects. Now that's not for everybody, and these cohorts overlap each other, but it is an important marker that we have to recognize. Models in diabetes and cancer-based healthcare have been exploring supportive education bridges to fill the gap after getting a new diagnosis, delay disease progression, and improve access to treatment and community-based programs. So BCPWA has 2 new models designed to address similar goals for people newly diagnosed with HIV. In year 1, we developed a workshop series for gay men who are newly diagnosed. It was really successful. We expanded it in year 2 to include everyone who's HIV positive. And now in year 3, we're developing what we call Peer Navigators. Now this whole workshop project has been funded by Public Health Agency of Canada, and we're very appreciative of that. I need a sip. Oh, right, my slides. Thank you. Except it's not working. Oh, there we go. Oh, and I'm going to have the same slide problem as you did. All right, so where are we here? Right here. Okay, so we're past that one. There we go. So we have 2 project goals. The first one is to educate people newly diagnosed with HIV about the value of care and treatment. And the second is to prevent disease progression and transmission. So I want to talk about the key influences of the first goal. Antiretrovirals are perceived as being as bad as HIV itself. The healthcare system can be confusing and disempowering. And by the healthcare system, I mean everything from doctors right through to community-based organizations. Doctors lack the time now to educate patients with basic HIV knowledge. Usually you get about 15 minutes with your doctor, a half an hour if you're really lucky. The other key factors in preventing disease progression is stopping or reversing disease progression saves lives. That's really a basic point. And engaging people when they are highly infectious, depressed, and at risk for transmitting the virus is an important factor. Our project vision. Our project vision is to promote HIV as a manageable chronic illness by providing the right information for a targeted group of people at the right time. So let's break that down. Providing the right information. It's important that information be accurate. It's important that it demystify. So if people have the notion that HIV equals death, or that their body is going to be completely morphed, then they're thinking about the second cohort, because that's what they see out on the street. And we have to let people know that that is not going to be their footprint. That's my footprint. Newly diagnosed people will have a very different footprint. So we need to demystify some of the tragedy of HIV for these people. We want to be hopeful. People come depressed, they come anxious, they come feeling that their life is over as they know it. And we really want to reposition that and say, this is not your whole identity. You had a whole identity before this, and HIV is just one part of it. You are not your virus. But at the same time, we need to be realistic, because this is not necessarily going to be the case for everybody. And there will be blips. There will be road bumps along the way where you will get sick and you may have to stop and take care of yourself for a brief time, but then you'll get better again and you'll be back on the road again. We want it to be non-clinical and accessible language. Most of the time when people come in to talk to us, they have no idea what their doctor has said to them. They have no idea what blood work means. They have no idea what viral load is and why it's important to know that. And as I said before, we want it to be relevant to new cohorts. Okay, so we want to talk about targeting groups of people. So we've kind of expanded from what Michael's definition of newly diagnosed is. We started out with the same definition, that newly diagnosed people would be people who had just been infected within the year. But we very quickly realized that we needed to move beyond that definition, because we were discovering that there were people who, when they spiraled away, stayed away from care for like 4 to 5 years, and they pretended that they didn't have HIV. And then they had a critical trigger in their life. They broke up with a partner, they lost a job, and those events triggered the, oh my God, and I have HIV, and I haven't done anything about that, and I need to start dealing with that. So all of a sudden they have all these issues that roll up on them. And so then we considered those people as newly diagnosed as well, because they're information naive and they have the same knowledge base as someone who's freshly infected. And recently, like within the last month, we've decided to expand the definition a little further to include those people who don't know that they're HIV positive. And this is a bit of a stretch for BCPWA, because our mandate is strictly for people who are HIV positive. So we had to kind of explore that for a while and go, okay, if someone doesn't know that they're HIV positive, but they are HIV positive, do they still fall into our mandate? And we decided that yes, they do. But what do we do with them? Because how do we find them if they don't know they're positive? So our way of attaching to that particular group of people is to get out and partner with prevention messaging. And finally, at the right time. Safer sex talk during a crisis point is an ineffective and insensitive time to be having a safe sex talk. For many HIV positive people who are receiving an HIV diagnosis for the first time, they hear it from a public health nurse. Part of the mandate for public health nurses that is passed down to them from the BC Ministry of Health is that they have to have a safer sex talk with somebody, and they have to do partner notification. Newly diagnosed people see partner notification as sex police. They don't want to talk about safe sex messaging when they have just found out they're positive. If you were a paramedic, you would not go to a crash scene bandaging someone's leg and say, while you're here, let's have a talk about your driving skills. We wouldn't do that. Why are we doing that in the HIV community? And finally, we want to be able to talk to people anywhere they are on the disease continuum, because some people find out they're positive when they're in the hospital with PCP for the very first time, and they have to deal with illness and a diagnosis all at the same time. So those people are newly diagnosed as well, and the messages that we give them are different than people who are newly infected right away. Okay, moving on here. So we have 2 different programs now. We have our workshop series and we have our Peer Navigators. Thank you. Our workshop series is a 2-day series of workshops designed to educate and empower. It's more structured and less directed. We share and ask questions with each other, and one of the goals is to decrease the shame-based isolation. We see a lot of isolation in the HIV community. Peer Navigators is a series of 3 one-to-one discussions designed to educate and empower. People newly diagnosed direct their own care and support needs, and the navigator assesses the needs and guides them through the process. It's like being a mentor. And finally, both models provide a safe and confidential space. Curriculum is the same for both. You'll be pleased to see, Michael, the curriculum covers everything that you brought up as issues for newly diagnosed people. At first, we talk about the new realities of living with a chronic illness. So the very, very first thing we do is we remind them, literally in the first slide, that they are not going to die right away. We remind them that they are going to live a long life, and we provide them with lots of statistical proof that they are going to live long lives into their 70s. We then talk about basic HIV disease, because as much as we live in this in the gay community with HIV, it's surprising how much people don't know about HIV disease. So we talk about disease progression, transmission, sex and risk assessment. We then move on to treatment information, when to start treatment. This is a huge discussion for people because they're not sure when they should start it, or their doctor has said, I think you should start it, but it's up to you. What do you want to do? I don't know. So they come to us and we have that discussion. We talk about medication options, and we do it in plain language. So in a matter of 10 minutes, we sketch out on a whiteboard what a virus looks like, what it's doing to your CD4s, what medication, why you're taking antiretrovirals, and how it works. And it works really well, and you can literally see the, oh, now I get it, look on people's faces. So then we talk about safer sex and other STIs, because harm reduction works really well to stop the prevention of HIV, but in the result is that we have all these STIs that we end up getting. So we have to have a discussion about that. We talk a lot about disclosure. Michael mentioned disclosure before. That is a huge, huge issue. So we develop strategies with them to help them meet their legal obligations, meet their personal challenges. How do I tell my partner? How do I tell my family? And we explore, well, why do you need to tell your family? And we actually take that apart and we give them a little bit of structure to walk away with and go, okay, now I have that sorted out in my mind. I have a plan. And finally, we talk about navigating the complexities of self-care. There's a lot of stuff out there, from antiretrovirals to naturopaths to massage. There's a ton of stuff out there, and people are really confused, and they go online, and they fall down that dark black hole of the internet, and they make it worse for themselves. So we have fallen down that hole, figured out what's good stuff and what isn't, and we compartmentalize that for them in nice, neat little packages. And finally, we talk about our doctors. We talk about finding a good doctor. Drop-in clinics are not a good, appropriate way to be taking care of your health. You need a long-term doctor. You need to understand your blood work, and you need to understand how to talk to your doctor about your sex life. The benefits of a newly diagnosed services. What we have seen is that supportive education bridges combine support and education initiatives. So we have elements of peer counseling, we have elements of traditional treatment information programs, and we have elements of personalized wellness planning. So this is fairly new because traditionally in the HIV community you have your education department and you have your support department, and they hardly ever talk to each other. So this is a blending of those two departments and programming ideas. We build trust with a knowledgeable peer. Building trust with a knowledgeable peer creates a trusting entry point and easier access into treatment and complementary programs. So if someone is sitting down talking with me and I talk about my experience, it's easier for them to then go, oh, I can do that too. That works for me. It doesn't feel out there. Participant feedback indicated they feel more connected to a topic by a peer rather than by a professional. Almost every time I have a conversation with somebody, they go, well, what do you do? What works for you? It's kind of some of that stuff we talked about earlier, or that the gentleman talked about earlier, about pushing the boundaries a little bit. As a peer, I can push over the line a little bit and talk a little bit about what I'm doing, not so that they copy me, but so that they break down and relax and go, oh, well, that doesn't work for me, or this is what works for me. But if I say, what do you think will work for you? They'll say, well, I don't know. Or they just don't want to talk about it. So if I can open the door a little bit by talking about some of my own stuff, then they talk about their stuff as well. We use inclusive language instead of jargon or medical terminology. We increase referrals between community partners. So rather than saying, oh, go to Friends for Life, I can give them our card, or I can phone Friends for Life and say, this newly diagnosed person is coming and they're struggling. Make sure that you catch them, because people fall through the cracks. And if it's hard to access an agency, then they won't come back. Increasingly, an immediate response is preferred over asking people to wait until they have to participate for a workshop. So this is the challenge we're running into, is that to get enough people for a workshop, it can take up to 6 to 8 weeks. Well, we'll lose them. So we've decided that peer counselors are a way to, or peer navigators are a way to catch those people right away. So they have an option, and I have to say that they're mostly choosing peer navigators at this point. We have some lessons learned. So we made some mistakes along the way, and we learned some things along the way that didn't work. Workshops in Vancouver, the lag time for first contact, as I talked about. Committing to 2 full days was really intimidating. For some reason, people don't want to commit to the 2 days. Although once they take the workshop, they go, I can't believe that this isn't for everybody. Everybody should have to do this. But there's that initial, I don't want to have to dive into it thing. Workshops outside of Vancouver. In our first year, we went to Victoria and we went to Kelowna. Victoria was hugely successful. Kelowna really struggled, but we pulled it together with them. In year 2, we tried Prince George, and Victoria's Vancouver Island wanted to do it in Nanaimo. It didn't happen. And in both cases, geographic isolation makes it really difficult to pull a workshop together. We have transportation issues, hotel and childcare expenses are more difficult to get people to, and there is the whole issue of the stigma in smaller communities where they might run in, if they go into an HIV organization or a group, they may run into their partner's mother or their sister's best friend, and they're not ready to come out to their community yet, and if they do, it could be very life-threatening. Lessons learned from peer navigators. Now we're like just into this program, so we're learning as we go along. Participants are lacking the benefits of sharing their story. The one good thing about workshops, well, there's many, but one of the things is that people get to hear from other newly diagnosed people what it's like to be newly diagnosed, what it's like to hear that message that you are now positive. In a peer situation, you don't really get that same interaction. Participants and peer navigators need to get to a relatable and trusting interaction with each other quickly. So it means I have to figure out what am I going to talk about, and they have to figure out what they want to talk about really fast. And usually they don't want to talk about their sex life right up front with a stranger. So we have to kind of negotiate that stuff, and I have to do it in a way that happens quick enough that I don't lose them. I want them to come back. Paid staff in smaller communities already are using a one-to-one model. In many small communities, we discovered that the advocate and the case manager, and sometimes even the treatment information or education person, are all the same person. And so they already have a one-on-one relationship with many of their clients, but they lack the knowledge about what it means to be HIV positive from a peer perspective. 5 minutes? That's great. I'll be great. So in summary, early HIV detection is important to prevent disease progression and HIV transmission. HIV-positive people that spiral off the grid at point of diagnosis increase the likelihood of HIV transmission, disease progression, and healthcare costs. Education that HIV is a manageable chronic illness for the third cohort will continue to meet the care and needs of previous cohorts. So this doesn't mean that we stop taking care of those people like myself who are aging with HIV and who are dealing with all kinds of inflammatory organ issues. We can do both. We can work with both communities at the same time. HIV-positive people are more likely to make healthy choices for themselves and others when given HIV information that is time-sensitive, relatable, and relevant. And that's me. Thank you.